we're going to do a review of labor and delivery. Labor is the coordinated sequence of rhythmic, involuntary, intermittent uterine contractions, and delivery is the actual event of birth. You have the 4 P's. These are 4 major factors that all must interact together for a safe delivery. You've got the first P is power. That's the uterine contractions, the forces that are needed to expel the fetus and placenta. You have passageway, and that is the mother's bony pelvis, the cervix. All of the, basically the openings for the vagina to ensure that there is a way for the fetus to be expelled. The third P is passenger. That's where basically you have to think about the baby, all the membranes and the placenta. And then last is psyche, and that's the woman's emotional structure. She could be experiencing a lot of anxiety, a lot of fear, and that will affect the delivery. Some different terms here. Attitude, it's the relationship of the fetal body parts to one another, such as you could have like the fetal back is rounded, head is forward on the chest, arms and legs are folded in against the body. It's basically a description of the relationship of the fetal body parts. Lie is the relationship of the spine of the fetus to the spine of the mother, such as it can say, well, the fetal spine is parallel to the mother's spine. Presentation is the portion of the fetus that enters the pelvis first. Could be head first, butt first, that would be breech, shoulder first, or a leg, an arm. And presenting part, that's the specific fetal structure that's lying nearest to the cervix. And station. And station is the measurement of the progress of the descent in centimeters above or below the midplane from the presenting part to the ischial spine. So station 0 is at the spine. Minus station would be above the ischial spine, or plus station would be below. And then when they say it's engaged, the engagement, that's when the widest diameter of the presenting part has passed the inlet. It corresponds to a 0 station. So mechanism of labor, there's different terms here. We've got lightning or dropping. That's also known as engagement. It's when the fetus descends into the pelvis, usually about 2 weeks before birth. You'll see a pregnant woman sometimes, you'll notice that they're carrying lower, and that means that basically that the lightning or dropping has occurred. When you get closer to labor, Braxton Hicks contractions increase. These are basically just practice contractions for your uterus. The passage of the mucus plug, that is a brownish or blood-tinged cervical mucus plug. It's a lot of times you'll hear people say, "Oh yeah, I'm getting close to delivery because I'm going to go in labor soon because I passed my plug." Also, as you get closer to delivery, the cervix starts ripening, becomes softer, and it may begin to dilate. It can dilate, a couple weeks ahead of delivery. It can sometimes, people can walk around with 2 centimeters dilated. Something called nesting, and that's basically a sudden burst of energy that's experienced by the mother. It can occur 24 to 48 hours before the onset of labor. It's where suddenly they just get this burst of energy and they want everything to be clean, and they're trying to get everything ready for the baby, and that's called nesting, and that's usually a sign that they're going to be going into labor soon. And then, of course, the spontaneous rupture of membranes, basically the breaking of the water. That's pretty much so a pretty sure sign there. You can have false labor. False labor, of course, is when contractions are felt more in the abdomen, and they're more annoying than painful. They hurt. True labor, the contractions increase in duration and intensity. Cervical dilation and effacement are continuously progress with the engagement descent of the fetus. False labor, the contractions are irregular and they do not produce dilation, effacement, or descent. I know that I had heard if you can talk or walk through a contraction, it's not a real contraction. A real contraction will stop you in your tracks and make you gasp for breath. So, mechanism of labor. We have basically engagement, you have the descent, flexion, internal rotation, extension, restitution, external rotation, and then expulsion. A lot of different little steps here. I've got a diagram here. There we go. Kind of shows the baby going down the birth canal. This isn't really a birth canal, but it gives you an idea of kind of what's going on. Engagement is when the fetus first nestles into the pelvis. Descent is when the fetal head undergoes as it begins its journey through the pelvis. Flexion is the process of nodding the fetal head forward towards the fetal chest. You want them to put their head in close to their chest. Internal rotation, that occurs most commonly from the occipital transverse position. Extension is, again, enables the head to emerge when the fetus is in a cephalic position. That begins after the head crowns, so the head will crown. Restitution is the realignment of the fetal head with the body. Then external rotation, the shoulders externally rotate after the head emerges so that the shoulders are in anterior-posterior diameter of the pelvis. And then expulsion is the birth of the entire body. Leopold's maneuvers, these are basically just the ways that you would feel the uterus and feel for the position of the baby. So basically it would, if you can feel like if the head is in the fundus, you can feel the hard, round, movable object. It's, like I said, it's just basically palpating to determine where the baby is. So if you feel like a smooth, hard surface, you can usually determine that that's the back. So you would know the abdomen would be on the other side. If you feel some irregular knobs and lumps, that usually tells you it's probably hands, feet, elbows, or knees. During labor, they do monitor the fetus. It can be done either externally or internally. So fetal monitoring, it will display the fetal heart rate. It also monitors the uterus activity, frequency, and duration of contractions. And it monitors the fetal heart rate in relation to the contractions. Baseline fetal heart rate is measured in between contractions. Normal fetal heart rate is 110 to 160 beats per minute. And external fetal monitoring, that is when you'll have, they basically strap on it's called a TOCO transducer or a Doppler ultrasonic transducer that keeps track of the contractions and the fetal heart rate. You would do Leopold's maneuvers to determine where the back is located, and then the ultrasound transducer is then placed over this area and fastened with a belt. Internal fetal monitoring is usually a probe, electrode that's put into the presenting part of the fetus. The patient must be dilated 2 to 3 centimeters before internal monitoring can be performed. You want to look at different patterns in the fetal heart rate. If there's bradycardia or tachycardia of the fetus, bradycardia would be fetal heart rate less than 110. Tachycardia would be fetal heart rates greater than 160. If that occurs, you need to change the position of the mother. Often just changing the position of the mother, giving her some oxygen, and then checking the mother's vital signs. That will often help the fetal heart rate. You would look for basically variability. That's a fluctuation in the baseline fetal heart rate. Accelerations are brief temporary increases of the fetal heart rate of at least 15 beats per minute. And this can happen. It can happen just, the baby could be asleep. So, they sleep in utero. Accelerations are temporary increases. Did I already say the accelerations? Also accelerations, that is the increase of 15 beats per minute higher than baseline. And accelerations can also be when the mother is contracting, the contractions, and it's kind of squeezing on the baby. The baby's heart rate's going to increase. That's actually a good thing because it's showing that the baby is reacting. There's also early decelerations, and that's a decrease in the fetal heart rate below baseline. So again, this could be from the contractions, and then you'll see just the variations in the fetal heart rate between contractions. Some things that are not good would be late decelerations, because that would basically indicate that the baby's not getting enough oxygen. So, of course, whenever you feel like the baby is not getting enough oxygen, the biggest intervention is to immediately improve the blood flow and fetal oxygenation. Again, sometimes it could be just as simple as changing the position of the mother and giving oxygen. If she's receiving oxytocin, you would want to discontinue it. Check the mother's vital signs, and then it would need to be reassessed. Hypertonic uterine activity. Typically, in between contractions, the uterus is going to relax for 60 seconds or more. This relaxing, it kind of gives everybody a break. It gives the mother a break. It gives the baby a break. The baby's not being squeezed by those contractions. But in a hypertonic uterus, the uterus doesn't relax. It stays contracted. And what that's going to do is it's going to reduce the blood flow to the uterus, and it's going to decrease fetal oxygen. So again, there's that may be a case where they may have to do a C-section. It's always making sure that the baby's safe and the baby's getting oxygenated. There's 4 different stages of labor. Stage 1 is actually divided into 3 individual stages. You have a latent phase, which that's the longest. That's the cervical dilation from 1 to 4 centimeters. Uterine contractions occur every 15 to 30 minutes. And they're 15 to 30 seconds in duration. A lot of times they do this at home because that's, it's pretty early on. Stage 1, you have the active phase. That's when the cervical dilation is from 4 to 7 centimeters. Your uterine contractions are going to now start occurring 3 to 5 minutes apart and 30 to seconds in duration. And the last stage of stage 1 is actually the transition. And a lot of times they'll say, "Oh yeah, she's in transition." You'll hear that being said, and that's when the cervix dilates from 8 to 10 centimeters. The uterine contractions are every 2 to 3 minutes, and they're 45 to 90 seconds in duration, and they're very strong. Stage 2 is actually the expulsion of the fetus. You would think stage 2, the expulsion of the fetus would be the last stage of labor, but it's not, because having the baby, you still have a little bit more work to do. You've got stage 3, which is now delivering the placenta, and then stage 4 is the recovery, which lasts from 1 to 4 hours after the expulsion of the placenta. Now there's some medications that can be given to the mother during labor. Tocolytics is one of them. That's a class of medication, tocolytics. They help produce uterine relaxation and suppress uterine activity. Now that can be done to halt uterine contractions in case of like preterm. If it's too early for the baby to be born, they'll give a tocolytic to have the uterus no longer contract. Also, magnesium sulfate. That's a drug that's often given. This is a central nervous system depressant and anticonvulsant that causes smooth muscle relaxation. Antidote is calcium glutamate. Keep that under your hat because that seems like that's always a popular question. Calcium glutamate is an antidote. So this also helps stop preterm labor, but it's used a lot to control seizures in preeclamptic and eclamptic patients. High doses of magnesium sulfate can cause a loss of deep tendon reflexes. That would be a sign of some toxicity. So obviously if you're having toxicity, the first thing you always want to do is stop the insult. So you would want to stop the mag sulfate. Also some other medicines, betamethasone and dexamethasone, those are corticosteroids, and those will actually increase the production of surfactant to accelerate the fetal lung maturity. That's one of the biggest problems with preterm delivery is the babies with their respiratory system, and they don't have a surfactant which keeps those alveoli from sticking together. So corticosteroids will help increase the production of surfactant. Of course, some other medications would be like opioid analgesics to help relieve the pain. There's prostaglandins, which are used to ripen the cervix, makes it softer and causes it to begin to dilate and efface, and also stimulates uterine contractions. This is often when people say, oh, I'm going to go get induced. So they give them a prostaglandin to help induce labor. And then uterine stimulants, oxytocin. Oxytocin is, it stimulates the smooth muscle of the uterus. It increases the force, frequency, and duration of the contractions. Oxytocin is also what promotes milk letdown. All right, so for some obstetrical procedures, there's a Bishop score that can be used to determine the maternal readiness for labor, evaluate cervical status and fetal position. It's done before the induction of labor. If it's given a score of 0 to 3, basically you need a score of 8 or greater to say that the chance of a successful vaginal delivery is good. Induction is the deliberate initiation of uterine contractions. We talked about that with the prostaglandins. Amniotomy, that's an artificial rupture of membranes. That's when it's called the bag of waters. They can go in and rupture those. External version, it's an external manipulation of the fetus from an unfavorable presentation. Say a baby is breech, and they can often from the outside just externally kind of manipulate to turn the baby. Sometimes it's successful, sometimes not. I've heard it's very uncomfortable for the mother, but they give it a shot. It's best to have the baby come out head first. Episiotomy, that's an incision that's made into the perineum to enlarge the vaginal outlet and facilitate birth. This isn't done that often anymore. They used to say episiotomy, just going ahead and doing this incision, that it would heal faster rather than having the risk of tearing. But it's been found that it doesn't matter. I mean, sometimes some people don't even tear, so having an incision would be silly if they could possibly give birth without tearing. But they found that it doesn't facilitate a quicker healing. Vacuum extraction, that's basically when the mother's not pushing well. Sometimes they are given an epidural and they can't push, they don't feel anything. So at that point they'll go in and put like this little little suction device on top of the fetal head, and it basically kind of helps pull the baby out. And of course, cesarean delivery, that's when the baby must be delivered through a incision, typically at the very lower part of the abdomen. With cesarean birth, it used to be once a cesarean birth, always a cesarean birth, but they've started, I don't know how long ago, but started doing a lot of VBAC procedures, which are vaginal birth after C-section. And it kind of goes back and forth. For a while, doctors will say, oh yes, it's perfectly safe, and then they'll flip and say, no, it's not safe. So it kind of depends on your doctor and just how they feel and how they feel about whether or not you could have a vaginal birth after cesarean. It also depends on where the incision was. If the incision is horizontal, it's safer to do that. But if you had a vertical incision, like an emergency C-section, then you cannot do a vaginal birth after a cesarean. And that is because you're at a high risk of having your uterus rupture, which probably cause fetal demise and maternal demise. So that would just be, it's too risky. All right, can't change the screen here. Come on. Okay, well, here's a practice question. The nurse is assigned to assist with caring for a client who has been admitted to the labor unit. The client is 9 centimeters dilated and is experiencing precipitous labor. What is the priority nursing action? Now, remember precipitous, that means it's happening really fast. So what's priority? Do you want to add on oxytocin, which will increase the uterine contractions? Do you want to put the patient in side-lying position? Do you want to prepare the patient for an epidural? Or do you want to tell them to start pushing? And hopefully you said number 2, keep the client in a side-lying position. Don't want to give them oxytocin. They're already contracting. Epidural, well, they're already at 9 centimeters, so you can't do it that fast. And tell them to start pushing. Well, they're only dilated to 9 centimeters, so that's too early to push. So obviously, of course, the priority that says priority is always oxygenation. So you want to have the mother go lay on her side to help with the oxygenation. All right, that was it for labor and delivery. That was quick, huh? Now we're going to go into postpartum. So now she's had the baby. So now let's see. Postpartum is the period when the reproductive tract returns to normal non-pregnant state. This starts immediately after birth and is usually complete by week 6 following the birth. I'll talk a little bit about some postpartum meds here too. We have ergo-alkaloids. Those stimulate the uterine muscle and it produces a firm tetanic contraction of the uterus to prevent hemorrhage. That uterus has to contract even after the baby's born, because when it contracts, that's what stops the blood flow. That's what stops it. It's when the uterus is what's called boggy, when it's not contracting and it's soft. The mother is at risk of having a hemorrhage. So what you would want to do is do a massage. You want to massage the uterus because that helps stimulate it to start contracting. But then, of course, there's also these medications. The alkaloids will help that as well. Also, prostaglandins, again, it helps contract the uterus and helps to prevent hemorrhage. Some other medications that you might want to give is the RH immune globulin. So you want to give this medication at 28 weeks of gestation and then again within 72 hours after delivery. And this is used on RH negative mothers that may have been exposed to RH positive red blood cells. Excuse me. And also the rubella vaccine. It's given before the hospital discharge to a non-immune patient. So some changes after the mother's given birth is there is a rapid decrease in the size of the uterus as it changes back to a non-pregnant size. The uterus goes from about 2 pounds to 2 ounces in 6 weeks. This doesn't happen immediately. Some people think, oh, I'm going to have my baby and I immediately have a flat stomach as soon as that baby comes out. No, you're going to have that uterus, and that uterus is still large, so it doesn't happen. There's some things that will help it occur faster is breastfeeding. Breastfeeding, because it releases oxytocin, so that helps. Oxytocin, of course, makes that uterus contract, so it will hasten. That's why they always say, oh, you lose a lot of weight with breastfeeding. Well, usually it's because it's actually not losing weight. It's just decreasing the size of the uterus. Lochia is a discharge from the uterus. It starts off as blood. From day of birth until about day 3, you're going to have bright red. And then it's going to start turning more into a brownish pink, and it occurs from 4 to 10 days. Now it's called serosa. And then after that, it turns into a white discharge that is called alba, and it occurs from days 11 to 14 postpartum. The discharge decreases daily. Cervical involution, basically after 1 week, the muscle starts to regenerate. Changes to the vagina, your vaginal distension will start decreasing, even though the muscle tone will never be restored to a pre-pregnancy state. And then ovarian function and menstruation. And it just kind of depends on how quick that will start back, depending upon the person and how they're, it's basically a pituitary function. Typically, start having menstrual cycles within 1 to 2 months after giving birth. If you're not breastfeeding, and breastfeeding mothers, it takes a little bit longer, like 3 to 6 months. And breastfeeding mothers may not even have a period at all while they're breastfeeding. Something that's really important, they say, to some people I've heard, they'll say, oh, you can't get pregnant if you're breastfeeding because you won't ovulate. Well, not so true. It could be. It could be that you don't ovulate and that you can breastfeed and not get pregnant. But there's an awful lot of moms out there that were breastfeeding and got pregnant. So don't count on it. Some more changes to your breast. Your breasts become distended with milk on the 3rd day. Now you remember in the very beginning you're just going to have colostrum. The first 48 to 72 hours is colostrum. Then the breast will become filled with milk, and it's usually they become engorged approximately on day 4. Engorgement is no fun. It hurts, but you just want to breastfeed through it, and it'll usually clear up. It gets better very quickly. Urinary tract may have some urinary retention due to the loss of elasticity, tone, and loss of sensation in the bladder from trauma. Again, these are things that clear up pretty quick. GI tract, often constipation can occur right after giving birth, and usually you want to see the patient have a bowel movement by the 2nd or 3rd postpartum day, and hemorrhoids are very common. So some complications, cystitis. That again, we talked about that bladder having some trauma. They just need to drink plenty of fluids. A hematoma, they're going to be hurting in their the vaginal area. So you want to tell them to they can apply ice to that area to help reduce the swelling. Some other complications is that uterine. I don't know if it's atony. I'm not real sure how to pronounce it. Atony or atony, but that's that flaccid uterus. That's that bogginess where they're at risk of having a hemorrhage, and you need to massage it to increase that tone. Hemorrhage and shock. Here we go again. Typically, it's due to a boggy uterus, and an infection, and that's where placental fragments may remain. Now, if those placental fragments are in there, that's also when it's going to cause like a boggy uterus. Oh, more complications. All right, so we have mastitis, which is an infection of the lactating breast. With mastitis, the patient should rest. They need to wear a supportive non-underwire bra and maintain a fluid intake of at least 3 liters per day, and take analgesics to relieve discomfort, and take the full course of antibiotics. They need to continue to breastfeed through this. Subinvolution, that's caused by the retained placental fragments. And basically, retaining those placental fragments and vaginal infections can again cause that uterus to not contract. Thrombophlebitis, we know what that is. Patients should wear support stockings, apply warm, moist packs to the legs, and maintain bed rest with legs elevated. The patient should not be ambulating, as this can cause the thrombus to dislodge. Oh, practice question already. Okay. After delivery, the nurse checks the height of the uterine fundus. Which position of the fundus would the nurse expect to note? To the right of the abdomen? Now, wait a minute. You remember the fundus, where that is. That's the very tip top of the uterus, right? So right after delivery, where is it going to be? Which position would the nurse expect to note? Is it going to be to the right of the abdomen? At the level of the umbilicus? About 4 centimeters above the level of the umbilicus? Or 1 finger breadth above the symphysis pubis? So if you said number 2, you are correct. Should be around the level of the umbilicus. Right after delivery, the uterine fundus would be at the level of the umbilicus, or 1 to 3 finger breadths below it. If the fundus is 4 centimeters above the umbilicus, this may indicate that there are blood clots in the uterus that need to be expelled by fundal massage. If the fundus is noted to be to the right of the abdomen, it could indicate a full bladder. By about 10 days postpartum, the uterus will be in the symphysis pubis area. And we're on to care of the newborn. Isn't that baby cute? All right, so initial care. First thing you're going to do with a newborn, as a nurse, you're going to do an assessment. The APGAR score. That's taken at 1 minute and then 5 minutes after birth. I think I have a slide of the APGAR score, so we'll talk about that more in a second. Basically, you want to monitor their respiratory status, look for any signs of hyperthermia or hypothermia, and assess the baby for any gross abnormalities. You want to, if you need to suction the baby, you suction the mouth first and then the nares. You dry the newborn and stimulate crying by rubbing. You don't smack the baby on the butt like they used to always do in movies. You just stimulate the baby by rubbing it with a towel. Maintain temperature stability. You want to wrap the newborn up in warm blankets. You want to put a little cap on its head. Heat escapes through the head, so you got to keep that head warm. Place the newborn on the mother's abdomen or breast for the skin-to-skin contact to help promote bonding. You need to footprint the newborn and fingerprint the mother, and then place matching identification bracelets on the mother and the newborn. You don't want to lose that baby. Some newborn medications we need to talk about. Lung surfactant. We talked about this earlier with the baby if they're preterm, basically to replace surfactant and restore surface activity to the lungs. Eye prophylaxis, preventative eye treatment. Basically, eye drops like the erythromycin to help prevent any eye infections. Vitamin K, babies are deficient in vitamin K for the first 5 to 8 days of life. So all babies are given a vitamin K injection. It helps prevent any hemorrhaging. Vitamin K is important for clotting. Vitamin B also is given as an injection to the newborn before they even leave the hospital. They get their first vaccination. Here's the APGAR score. All right, so within the first minute and then again in the 5th minute, and it's basically a score. Tells how the baby's doing. It looks at what their appearance is, if they're blue or pale or if they're pink. Basically that's showing their respiratory status. You've got their pulse. We've got grimace. We have activity, their muscle tone, and respirations, either absent or a vigorous cry. So these scores, like I said, are added up. That 1 minute APGAR, and then you have a 5 minute APGAR, and it's kind of a quick, easy way to determine the status of the newborn. A score of 8 to 10, no intervention is needed. If they have a score of 4 to 7, they need to be stimulated. Rub their back, administer oxygen to them. Keep rechecking the APGAR score. If they have a score of 0 to 3, then they're going to require full resuscitation. All right, so with the newborn, you're going to do a physical assessment. Look at their vital signs, check their fontanelles, look at their skin, the genitals, the spine, extremities, all the body systems. All the body systems, you would do a full cardiovascular, respiratory, hepatic, renal, GI system, neuro. You'd want to do cord care, circumcision care, obviously if it's a boy. Part of the neuro is going to be checking reflexes and different reflexes that that babies have, and this is you have the sucking and rooting reflex, you've got swallowing, that's the tonic necks or the fencing reflex, the palmar plantar grasp, Moro, the startle, the pull to sit, Babinski, stepping or walking, and like a crawling movement. Those are all reflexes in newborns that need to be checked. Parent teaching is part of this newborn care. You want to teach them about formula feeding, like how to sterilize the bottle, not to heat up a bottle in a microwave. Breastfeeding mothers, you want to make sure that the baby can latch on, teach the mother how to pump and store milk, and also let them know that breast milk is sufficient for the first 4 to 6 months. They don't need anything else. They don't need any baby cereal or they certainly don't want any fruits or vegetables yet. Also bathing, they need to use a mild soap. They want to have all equipment available right there so they don't have to leave the baby, obviously, and go get anything. Bathe in a warm room before feeding. They need to make sure that they take special care to clean under the folds of the neck, the underarms, and the groin and genital area. Some clothing teaching to instruct them how often they need to check the diaper. Also that the newborn's head needs to be covered up during cold weather. The baby should be dressed in one more layer of clothing than the parent. I see some people just bundle those babies up and the babies are just sweating up a storm. Cord care, they want to keep the cord clean and dry. Use either alcohol to clean it if the cord becomes soiled. You want to make sure the diaper doesn't cover the cord. You want to fold the diaper down below it. Monitor the cord for any odor, edema, or discharge. You need to sponge bathe the baby until the cord falls off, which takes about 7 to 10 days. Circumcision care, you would want to apply petroleum jelly gauze to the penis, except when a plastibell is used. And clean the penis after each voiding by squeezing warm water over it. You want to observe for any signs of edema, infection, or bleeding. If any signs of infection occur, they need to make sure that the healthcare provider is called. With an HIV positive mother, the use of antiviral medication is given. It's help reduce the newborn exposure to the maternal blood and body fluids. Early identification of HIV during pregnancy helps reduce the risk of transmission to the newborn. Breast milk will carry HIV and the mother will not be able to breastfeed. And the baby will need to be tested regularly for the first few months of life. The baby will need the antiviral medication for the first 6 weeks of life, and strict care needs to be taken to make sure that the newborn doesn't get any infections. All right, some abnormalities. Preterm would be a baby born before 37 weeks of gestation. Primary concern is relating to the immaturity of the body systems, especially the lungs. So you want to make sure that you maintain airway and administer oxygen as needed. A post-term baby is born after 42 weeks gestation. This is after about 42 weeks is when the placenta is no longer functioning very well. So that's a lot of times when they want to go ahead and induce labor. Primary concern at this point is hypoglycemia. So you would want to definitely monitor the baby's blood glucose levels closely after they're born. Also, respiratory distress syndrome. Newborn may have cyanosis, tachycardia, apnea, nasal flaring, chest wall retractions, or audible grunts. Meconium aspiration syndrome, that often occurs in post-term newborns, but it's the release of the meconium, which is the baby's first bowel movement, into the amniotic fluid. It's thought to be related to a stressful fetal event. You know, being born is pretty stressful. Aspiration can occur in utero or even with the first breath. Respiratory distress is present at birth. If the baby's inactive and a lack of cry, then they may need endotracheal suctioning. They may need additional interventions. Hyperbilirubinemia, that's the elevated bilirubin level. Newborn will be icteric. What's icteric? That's jaundice, right? So you want to prepare them for phototherapy. That reduces the bilirubin levels. So you want to expose as much of the newborn's skin as possible. So you need to reposition the baby every 2 hours. Everything except for the genital area. So you keep the diaper on. Eyes need to be covered with shields, and the shields removed at least once every shift to inspect the eyes, make sure that they're not irritated or have infection. And the quantity of the light should be monitored every 8 hours. Monitor the skin temperature closely and increase fluids to compensate for fluid loss. Newborn of a diabetic mother. Newborn may exhibit hypoglycemia, hyperbilirubinemia, hypocalcemia, birth trauma, and respiratory distress. The baby may be in excessive size and weight as a result of excess fat and glycogen in tissues. You want to closely monitor the newborn's bilirubin and blood glucose. And fetal alcohol syndrome. Those newborns have craniofacial abnormalities. They usually have intrauterine growth restriction. They've got cardiac abnormalities. They'll have an abnormal palmar crease and respiratory distress. Practice question. All right. The nurse is reinforcing measures regarding the care of the newborn with a mother. To bathe the newborn, the mother would be taught which intervention. Do they want to begin with the eyes and face? Or start with the dirtiest area first? Or begin with the feet and work upward? Or only wash the diaper areas, because this is the only part of the baby that gets soiled. All right, we'll just think about that. Do you wash the dirtiest area of your body first, or you save that for last? Hopefully say you save it for last. So answer is number 1. You want to start at the eyes and face, which are usually the cleanest areas. Then you go down, work your way down behind the ears, newborn's neck. A lot of times formula or breast milk will all get in those folds and it gets all stinky. Hands and arms are washed, then their legs, and the very last part to wash would be the diaper area. One more practice question and then we're done. Pregnant client is receiving magnesium sulfate for the management of preeclampsia. The nurse who is assisting and caring for the patient, wow, I don't know, my typing is not too good here, caring for the patient, that the client is experiencing toxicity from the medication, if what findings are noted. Okay, so basically she's caring for this person that's on receiving magnesium sulfate, and she is looking for things that would basically show that the patient might be experiencing toxicity. Select all that apply. So proteinuria of 3+, respirations of 10 breaths per minute, presence of deep tendon reflexes, urine output of 20 mils in an hour, or serum magnesium level of 6 milliequivalents. Select all that apply. So the answers are 2 and 4. 2, respirations 10 breaths per minute, we can see that that's too low. And then 4, the urine output is really low, right? Magnesium toxicity can occur from the mag sulfate therapy. Signs of toxicity relate to central nervous system. Depressant effects of the medication include respiratory depression, loss of deep tendon reflexes, and a sudden decline in fetal heart rate and maternal heart rate, blood pressure. Urine output must be at least 25 to 30 mils per hour. And therapeutic levels of magnesium are 4 to 7.5. Proteinuria of 3+ is an expected finding. So it was the urine output and the respiration rate that were abnormal. Alrighty, this concludes labor, delivery, postpartum, and newborn care.